So, uh, thanks very much. Good afternoon, everybody. I'm Ami Banerjee. I'm a cardiologist and epidemiologist in the Institute of Health Informatics at UCL. I'm presenting on behalf of a team of people who've been doing the work, and I've mentioned some of the people who've been doing analysis at UCL, but there's obviously Kathy and everybody who's put together the consortium, people who've put together the codes, and so on, so without which this wouldn't happen. So I'm going to talk about direct effects of the pandemic on mortality. In the kind of seminal Open Safely paper, I say seminal because it really opened our eyes to the power of national linked data, and also looked across all the risk factors for COVID mortality. But the question was being asked from the direction of what are the risk factors for COVID-19 mortality? And we came at a different angle, not because we came up with that question, but because a patient asked what's their excess risk due to the pandemic versus their baseline risk. And so our team at UCL in the middle of March last year quickly cobbled together analyses using the data that we had available, which was CPRD historic data, to model baseline risk and to try to model based on what we knew already at that stage about the impact of high-risk conditions on mortality, what the impact might be on excess death. And you'll be aware that at that time there were very few deaths, and now the official statistics are 128,000 in the UK. And that was preprint on the 22nd of March, and on the 12th of May, it was published. And the premise was this, that the key issue is baseline mortalities. So this varies based on number of conditions, based on gender, and based on age, from nearly 0 to 28% over 1 year in men, for example. And so we came up with estimates, if you look in the third column along, that if 10% of the population was infected over a year, then we would expect in the high-risk groups in the order of 70,000 excess deaths based on a relative impact of the pandemic above baseline risk of threefold. This model we've used in various ways, and so have others, but just to give a flavour, we've looked at cancer patients and cancer services. It's been used to look at high-risk individuals using global burden of disease data in all countries, cardiovascular disease patients, recently to model what the impact of vaccination might be in high-risk individuals in the Canadian context, and the impact on obesity. So the CVD COVID consortium and the TRE gives the opportunity to look at whether our model was in the right ballpark and which parts of the model are important, if any. So the underlying cohort is rather complicated. But if you look at the right, first of all, we stuck with high-risk conditions that we'd looked at in that Lancet paper. So cardiovascular disease, diabetes, chronic kidney disease, people with chronic lung disease, obesity, and age over 70. And then I've got the definition that we used for cardiovascular disease and diabetes. And we've also looked at diabetes and cardiovascular disease. And I should say these are preliminary analyses. They do need to be scrutinized and polished. But the idea is that we were interested in the pandemic period, which we defined from March 20 to March 21. And we looked at historic data starting from 1977, because prior to that, things like date of birth and missing data were an issue. But we we picked patients with these high-risk conditions, incident and prevalent, and I can speak more to that later if people are interested. And so if you look at the red lines here, then I've outlined some potential cardiovascular disease patients who are incident, and incident in the sense that their cardiovascular disease happened in the pandemic period. So on the left-hand side is a figure from our Lancet publication just about baseline risk in the CPRD cohort. So we looked as much as we could at the same risk factors in the TRE data. And so on the right here, I've got the number of deaths. And by excess deaths here, we mean people who've got COVID-19 code and died. And we've got the pre-pandemic mortality risk and pandemic mortality risk. So broadly, the pre-pandemic mortality risk estimates, as you might expect, are similar to what we got CPRD, but we see across all the high-risk conditions really frightening one-year mortality risk in these high-risk conditions. And the denominator here is people who have who have the risk factor and have COVID. Of those, what proportion died in 1 year? And so, for example, under cardiovascular disease, during the pandemic, the 1 year mortality risk was 27%. In over the age of 70, people who had a COVID code at any point during the year, it's nearly 30%. And we, in our analysis originally, we talked about this relative impact. How much does the pandemic add to your baseline mortality risk? So we've tried to do that to the right of this slide here. So if you look at the bold pre-pandemic column, that's comparing the COVID mortality with these risk factors versus the pre-pandemic period. And you'll see that the relative risks vary between 3 and 5 or so for the different conditions, the highest being for over 70 years and the lowest for people with cardiovascular disease and diabetes. We've also compared, during the pandemic period, people who died, the mortality risk from COVID with the mortality risk of non-COVID with that risk factor. And what's interesting there is that you'll see the relative risk estimates are slightly higher across the board, which I'll come back to, suggesting that the non-COVID mortality is not as much as we might have thought. And we've also looked using codes that Johan Tegersen, Spiros Danaxis, and many others have been leading work on looking at the coding of COVID in our data sets. So using those codes, we've looked at the infection rate in people with these risk factors. In the overall population, the background population, I should say the infection rate is 5.8%. And you'll see that there is some variation across the high-risk conditions between 5 and 9 in this case. We know that even from first wave data from ONS, that the the estimate of seroprevalence at that time was 10%. And so, there's various estimates in the last couple of months, which either because of vaccination or infection suggest more like 50–60% seroprevalence. But we would assume that this is an underestimate of infection rate for various reasons that, again, we can discuss. And just a deeper dive into chronic kidney disease here, just to look at what might be happening. Top left here, this is comparing mortality with the previous year and coming up with a relative risk estimate. And you'll see that there's been, as is well documented across all high-risk conditions, there's been an increase in mortality during the pandemic. There's also changes in relative risk over the period of the last 12 months, with a spike you can see there in the first wave in March, April. And when I'm looking at the bottom left here, the blue line, and if you take away the COVID deaths, there was a non-COVID death spike for people with CKD, but that we saw with people with cardiovascular disease as well in March, April, which has tailed off for the rest of the pandemic. If you then look at the top right, interestingly, in this data set, but again, this has been reported elsewhere, there's been a change downward, a decrease in incidence of CKD in the last year, and why that is moot. But people like me who are expecting large indirect effects haven't necessarily seen that in large linked data sets so far. And then finally at the bottom, of similar to the top left curve, we plotted all-cause mortality over years. We had published various predictive models based on different relative risk estimates, different infection rate estimates. And so, for example, in that Lancet paper, we had predicted about 70,000 deaths with a relative risk of 3 and 10% infection rate. Obviously, there's far more deaths. Is that because there's greater infection rate than 10%? Almost definitely. Is the relative impact of the pandemic higher than our estimates? Probably. And you can go down the list that across all of the estimates, we've, if anything, underestimated. And so this is preliminary data. We need to look at this much more closely to see what might be driving this and how it differs across diseases and across combinations of diseases. I've mentioned that we may be underestimating, not maybe, I think we are definitely underestimating infection rate, but this is as good as you can get in national linked data to pick up people who've had COVID. We have included people who have a positive COVID code and have died. So that's, whereas you'll be aware that others estimate that based on 28 days from their diagnosis of COVID. We're going to do sensitivity analysis around that as well to see how that changes number of deaths. Whether we have overestimated the relative impact because of the previous points. We need to look across underlying conditions, and we need to look at cause of death and non-COVID deaths. This is of interest to lots of other groups, and others are working much more on this. So the Global Burden of Disease has updated its methodology in the last month. And if you go to their website, you'll see they're now thinking about excess mortality under a framework of 6 headings, really. So the total COVID mortality death rate, indirect deaths due to healthcare being delayed or deferred, increases in mortality due to increases in mental health disorders, which are listed here as depression, alcohol use, opioid use, a reduction in mortality due to injuries such as road traffic accidents because of social distancing and other restrictions. 5th, a reduction in mortality due to reduced transmission of other viruses such as influenza. And finally, the fact that people with long-term conditions such as cardiovascular disease aren't dying with cardiovascular disease because they died with coronavirus. So I think these type of estimates around relative impact and infection rate are important on an international scale. But pragmatically, nothing's changed really. Keeping the infection rate down, whether pre-vaccination by social distancing and lockdown measures, and now by vaccination, as well as reducing the baseline mortality rate by making sure that people are diagnosed and treated for underlying conditions. And then it's clear that we have had a big relative impact across the health system, which is reduced by making sure that the health system is not strained. Happy to take questions. Thank you.